segue. I feel like we could probably ask you all questions for the next several hours, but we needed, I think, transition over to the evidence that we know. And so Dr. Shalkowski, I'll turn it over to you. And then to our experts, there's a couple of questions in the chat that we didn't get to. Feel free to answer them. But Dr. Shalkowski, we're looking forward to hearing sort of what we do know about the evidence. And you're muted now, but I think we're going to get your slides up in just a second.
Okay. Do you want me to pull up my version of the slide? Okay, Bajali. Thank you, Bajali. Bajali, I'm not yet seeing the slides. Is anyone else seeing them?
No, there's still just a started screen sharing. Nicole, maybe do you want to try and
Sure.
share?
Let me see.
But it doesn't seem to be working on your end. If you want to just cancel your share and we can let Dr. Shalkowski share. Yep, there we go.
Okay, is everyone seeing that?
Yes, thank you.
Okay, great. Okay, so I wanted to just finish up by reviewing the various types of clinical presentations and briefly comparing it to Kawasaki's disease as sort of a similar presentation to MISC, but we're going to focus mostly on some of the evidence base that's come out over the last 12 months and best practice guidelines in terms of treatment. I'll touch briefly at the end on the 6-month follow-up outcomes and prognosis, and then end by talking a bit about the presentation of the vaccine-associated myocarditis. As several have alluded to already, there seems to be 3 distinct syndromes with MISC, one being prolonged fever with elevated inflammatory markers and variable symptomatic presentation, a syndrome that's very similar to Kawasaki's disease, and then the one we've been focusing on today in the case presentation, shock with myocardial injury. Unfortunately, there is no single diagnostic test, but the patterns of inflammatory markers can really help differentiate this disease process from other disorders of inflammation that we see commonly in children. The good news is that most children do have very rapid recovery with IVIG and steroids, but at this time there's limited data on long-term outcomes beyond 6 months. The first case report really was out of London back in April of 2020 that was published in The Lancet. And this case series by Verdoni was out of Italy, published shortly thereafter in May. And so Verdoni's case series was really the first one really describing this as a new syndrome during the pandemic. And if you see on the graph on the right-hand side there, the majority of cases were starting to be seen 4 to 6 weeks after the height of the epidemic, suggesting, again, a post-infectious inflammatory syndrome. If you look at the incidence of Kawasaki's disease in that same region in Italy, you can see that the diagnosis of Kawasaki's increased 30-fold during that period of time, not knowing that this was really a brand new presentation of a brand new disease secondary to COVID-19. As we all know, Kawasaki's disease is an acute vasculitis of medium-sized vessels and presents with the symptoms that you see there, a lot of overlap with many of the tropical diseases that my colleagues had discussed, and certainly now an overlap with MISC. The lab presentation is quite similar in the presentation with leukocytosis, thrombocytosis, elevated inflammatory markers, low albumin, anormocytic anemia, and sterile pyuria in the urine. The cardiac findings can be quite similar, although, as mentioned previously, are less common in Kawasaki's and now more commonly seen in MISC. The epidemiology here differs significantly, and this is what helps us differentiate now Kawasaki's presentations from MISC. Kawasaki's disease is really a disease of young children with a peak between 6 to 11 months. And usually has seasonal clusters, whereas now we're seeing MISC throughout, regardless of seasonality. The MISC presentation is similar but different. And this little infographic here shows you sort of the most common symptomatic presentations. And you can see that LV dysfunction is much more common, with coronary artery dilatation in MISC being up to 17% in different case series. As was mentioned previously, digestive involvement is seen in up to 80% of patients, with many patients presenting with nausea and diarrhea. That's relatively uncommon in Kawasaki's. And in this particular case series that I quoted here below, several patients had actually gone for exploratory laparotomy because there has been confusion given the GI predominant symptoms with appendicitis and other abdominal emergencies. These are the CDC and WHO criteria that we've utilized here in the United States. There's also the definition that you see below there from the Royal College of Physicians in the UK. Really the fever is the predominant initial presenting sign for at least 24 hours in the WHO criteria for more than 3 days, and multisystemic involvement. The laboratory evidence of inflammation we're going to speak a little bit about because there are some markers that I think are quite helpful to distinguish MISC from other etiologies. Inflammatory markers can help distinguish patients who are at risk of shock, but not who are at risk for coronary artery abnormalities. This was data out of a publication in JAMA by Whitaker et al. So for children with MISC who do have shock as their initial presentation, they had overall higher inflammatory markers with higher CRP and neutrophils, but lower lymphocyte counts and lower albumin. They did have elevated troponin and pro-brain natriuretic peptide in their initial laboratory presentations. But unfortunately, in this case series, there was no clinical or laboratory data that helped to predict children who were going to develop coronary aneurysms. These are from that same paper by Whitaker, and these are patterns of inflammatory markers that help to distinguish MISC from other inflammatory conditions. As you can see here in this case series out of the UK, they call MISC PIMS, pediatric inflammatory multisystem syndrome. So on the left-hand side, you can see here that in this first graph, the older age of presentation is quite strikingly different from conditions such as Kawasaki's disease, toxic shock syndrome, and Kawasaki's disease with shock. And the higher troponin and higher D-dimer are also quite differentiating for this population with MISC. These were some data that were published in JAMA in January of 2021, and then subsequently in June of 2021 on the association of IVIG and methylprednisone versus immunoglobulins alone. So I wanted to show that data because I know that in some contexts, IVIG is not available. And as Dr. Arun alluded to, sometimes out-of-pocket costs, particularly for IVIG, can be a challenge in some settings. So in the New England Journal article, which studied over 600 children from 32 different countries, there was actually no evidence that recovery from MISC differed after primary treatment with IVIG alone, IVIG plus steroids, or steroids alone. So I think that's still early data, but a reasonable cohort, a reasonable N there. So I think that's good news for those of us who've practiced in settings where perhaps IVIG is prohibitively expensive or not available. In the JAMA study of over 180 children who fulfilled the WHO criteria for MISC, again, treatment with IVIG and methylprednisone versus IVIG alone, There was some association with a favorable course of fever and defervescence. However, it seemed to be the addition of the steroid that made the largest difference. This was very recent data, just published last month in June in the New England Journal of Medicine on initial therapy and outcomes. And it looked primarily at cardiac dysfunction in children who met the case definition of MIS-C with a median age of 8.7 years. Initial treatment with IVIG and steroids in this population was associated overall with a lower risk of persistent cardiovascular dysfunction than treatment with IVIG alone. So again, steroids seeming to be the key here for patients presenting with significant cardiac dysfunction. In our pediatric ICU, we manage the shock component very similarly to how it was managed in the case presentation by my colleagues, with initial volume resuscitation being in 10 cc per kilo aliquots if there is evidence of dehydration or shock. And then we use ultrasound of the IVC and the clinical hemodynamic response and physical exam findings to guide our subsequent fluid resuscitation. In regard to vasoactives, very similar to the case presentation, if patients are presenting with shock and poor perfusion, we start with adrenaline at the doses you see there and titrate to effect, and then add milrinone if oxygen delivery remains inadequate, as assessed by the physical exam findings that my colleagues alluded to earlier. In patients who present more with a vasodilatory picture with warm shock and hyperperfusion, we typically start with the septic shock guidelines and begin with norepinephrine and consider addition of vasopressin as a second vasoactive. We have here hydrocortisone. That's sort of according to the typical shock guidelines. This is in all patients who are presenting with shock, regardless of diagnosis. However, if it is MIS-C, we will opt for glucocorticoids as well as early as possible, given a high index of suspicion. Someone in the chat asked about the risk of thrombosis in this population. In a systematic review of over 80 studies, thromboembolic events were quite rare in pediatric patients, both with acute COVID infections and MIS-C compared to the adult population, but anyone with a comorbid condition is predisposed. So in our practice, we have typically used enoxaparin if patients have any evidence of coronary artery dilation. And then after the ICU stay is completed, typically they are converted over to aspirin as an outpatient. Much like in Kawasaki's disease, we use high dose aspirin for the first 48 hours or until the patient defervesces, and then switch over to low dose, which is continued until the patients are seen outpatient with follow-up echocardiography. This is the most recent study that I could find about follow-up care and follow-up outcomes. This documented a cohort of 50 children who were treated with immunomodulators of some sort after diagnosis with MIS-C and looked at their prognosis at 2 weeks, 4 weeks, 6 weeks, and then finally at 6-month follow-up. And again, the good news is that prognosis overall has been quite good if patients are treated early on with some form of immunomodulators, with return to functional baseline, for the most part, normalization of LV function and resolution of the coronary artery abnormalities. There have been case reports of persistent diastolic dysfunction at 6 months, and it's unclear at this time what may predispose patients to that persistent dysfunction. Lastly, just wanted to end by mentioning this. This is the website of the CDC, and in April of 2021, we started seeing reports of myocarditis after the mRNA vaccinations in adolescents and young adults. And now we are seeing in the literature a few more case reports. The one on the left is out of Israel, since they have some of the higher vaccination rates now of adolescents in the world, really. And the one on the right is a case series coming out of the US. As I mentioned earlier, there seems to be a predilection for males. In the US case series, all 6 patients in the case series reported were adolescent males. So again, just we are having a high index of suspicion for this, since most of our adolescents are being vaccinated now above the age of 12 with either the Moderna or Pfizer vaccines. So time will tell how this plays out. But I think overall we are, as pediatricians, still very strongly encouraging vaccination in the pediatric population, because this seems to be a very rare complication of the mRNA vaccines. And just wanted to mention that there are multiple different clinical management algorithms. I think there's really no one fits all approach. A lot of this very much depends on your setting and the resources available in your own environments. But there is a very nice online algorithm that we have used in our institution as well. We have one at Johns Hopkins, but the Children's Hospital of Philadelphia algorithm has a lot of very nice embedded links within it. So for anyone looking for sort of a very nice interactive algorithm to use, I think this is one that many of us in pediatrics are using. And really trying very hard to share data and share outcomes, since we are all learning as we go, and admittedly learning from each other's experiences. So these are the references that I cited in this presentation, and happy to share these slides with all of you, as well as the recording. So thanks very much for inviting me to speak today. And I hope this was helpful to inform all of our practices.
Thank you so much, Dr. Szolkowski. That was amazing, and I think a very comprehensive review of the literature. It is 9:30, and I just will make one comment about what struck me. I think it's very impressive how far science has come, and we are in a very challenging time, of course, but 15 references for a disease and process that is maybe a year old, many with lots of patients, and then the opportunity to sort of share our knowledge across the world, really, I think is an exciting time. We obviously have quite a bit of work to do, but I think a very impressive presentation. Thank you to all the presenters and for all the participants here. Just to remind everybody, you will get a post-test. You'll also get a resource document that will have a lot of the relevant references and a few clinical pearls. And I will just sort of put a plug in for our next session, which is here August 19th. We're going to talk about how to wade through some of the therapeutic management of COVID-19. Dr. Paul Allwater will be our expert from Johns Hopkins University. We hope to see everyone there. And then I will make sure nobody else has any other comments. Bhakti and Dr. Antari, I don't know if you have anything else you'd like to add, but again, I think this was a wonderful session, and we're very appreciative of everybody participating.
Thank you, Savik. And I just want to hear the contact details for our USAID RISE India team. Ms. Bajoli Sinha is someone that you are all very familiar with. Ms. Dr. Jen Daniels, Dr. Surinder Sharma, and Dr. Nochiketa Mohanty. We are working pan-India across every single state. RISE is now going to be supporting over 5,000 health facilities. So if you have questions, need support, have identified areas of need, please reach out to any of these individuals. Their email addresses and telephone numbers are available to you. This is just a tip of the iceberg, and there is a comprehensive package of support that our teams can provide in order to support our pan-India strategy. So with that being said, thank you and good evening, everybody. We'll see you again in 2 weeks to discuss the latest and greatest on therapeutics. And I'm hoping we'll have a good discussion on the new monoclonal antibodies and perhaps even our concerns or potential strategies with their interaction with TB. I'm going to end the session right now and then invite those panelists who are willing to stay on and any participants who would like to ask questions to continue, but officially we are closed. Dr. Bansal, I was reading the Scottish study recently that compares the Alpha variant to the Delta variant, the large health system study. And what it was really showing was that with Delta, we are seeing children between 5 and 9 were much significantly more likely to get COVID compared to the Alpha. Nick, do you concur with that finding that children seem to be more vulnerable to COVID with the Delta variant? Or is the higher number of cases because a larger proportion of adults are vaccinated?
Yeah, that's an interesting question, Bhakti. At present, like in our wave, which we had in April, May, bad time which we had done our own serologies and the genotyping of these viruses. So there were few Delta variants even then in our population in April, May here. Even in Chandigarh and in other parts of the country, there were, we found Delta virus was present. But it hasn't affected so much the pediatric population like it was expected. Though we saw a large number of pediatric patients, but they were because there were more numbers, but percentage wise, they were not so much increase in them. So I don't think that Delta virus will be affecting so much of the pediatric patients as it has been anticipated.
That's promising since I have 2 young children at home, as do many of our panelists here. Any other questions? We can always, and Arun, would you mind just mentioning briefly some of the courses and training opportunities that are being provided by the American Association of Pediatrics in Critical Care that may be available to the folks that are still on the call?
Yeah, okay. Means you want to meet for the Indian Academy of Pediatrics? Or
sorry, Indian Academy of Pediatric Critical Care. I'm so sorry.
Yeah. Okay. So IAP has been planning and is doing a lot of courses on the COVID management and training of the trainers, and also training the healthcare workers who are the nurses and other staff on this subsequent third wave. So we have started TOTs for the West Bengal. We have started TOT at Madhya Pradesh. We are doing the TOT in the pipeline in Punjab. And the next, we are going to start with the Karnataka government. So once these are formalized, we are going to do it pan-India on that. Also, we have also done the COVID Uday and the COVID program on through the IAP, and we've done almost 100 workshops on that all over the country till now, from the January onwards till August. And we are also planning to start some a very basic, from the intensive care chapter side, very basic program which will target the grassroots level worker, that how to identify a case who had come with COVID or MISE, how to give basic treatment like oxygen, fluids, basic investigations, and start the treatment, and when to refer, how to refer. So these are the kind of managements which are very lacking here at a village or a very small town. So we are targeting that. That's our next step. Hopefully we'll be starting that program by the end of August.
Great, thank you so much for sharing that. I did put in the IAP guidelines into the chat for everybody, but I think we should go ahead and close. I don't see any questions being posted. Thank you, everybody.
Yeah, thank you so much.